and welcome to today's webinar. And thank you very much for taking time out and being here today. And I want to introduce myself really quick. So my name is Ayong, and I am the Marketing and Educational Seminar Coordinator here at NeobiotechUSA. And hello and welcome again. And this is me right here. So today's agenda is to introduce our topic and our presenter, and I will also go over some of the communication tools and our upcoming webinars, and lastly about your CE. So I want to mention out that in order to receive your CE, you would have to stay until the end, and I will go over more details later. So today's topic is the future of implant dentistry is here, part one, and our presenter is Dr. Jeffery Platt.
Hello, everyone.
And so please be advised that your audio will be automatically muted when you join the webinar, and we are also strongly recommended to use the chat box. And we looks like quite a lot of people joined our webinar right now. I just want to wait maybe another minute to have them to join it, and then I will go over some of the communication tools you can use it. Okay. All right, let's jump into our communication tools. This is basically the Zoom features. So here are some of the Zoom feature communication tools that we want you to use to communicate with us. So the first one is the chat box. So if you are joining from a mobile, like your iPhone or Android, you will see a screen on your left. And if you are joining from a PC, Mac, iPad, etc., you'll see a screen on your right. It looks like this. There's a chat box here. So please use the chat box to communicate with me. Ask technical issues and other than the topic. And once you click on this chat here, you will see this drop down list here. So if you click on the all panelists, which means the Dr. Platt will see it. And if you click on the next one, all panelists and attendees, which means everyone in this webinar can see this message that you sent. If you happen to want to, to send message privately to the host, which is me, you can just click on my name. That way I will, reply to you. And the next one is the raise hand button. You can also raise your hand so then I will, send the message to you. And the next one is going to be a Q&A. So we will have a Q&A session at the end. So once you submit your questions, the Dr. Platt will either answer it live verbally or simply type answers and send it back to you. So please use the Q&A box, basically communicate with our course speaker, as I mentioned right here. And also please understand that Dr. Platt may not answer all the questions because we have a limited amount of time. And lastly, at the end of the lecture, I will have an important announcement about how to receive your CE and also upcoming webinars about Dr. Platt. So please don't leave and stay tuned until the end of the webinar. Okay, and let's have our of course, presenter, Dr. Platt, to start our webinar today. Good morning, Dr. Platt. How are you doing?
Joyful, how are you doing, guys? Hopefully you're enjoying my house. I'm coming to you from my office and my house, and then this series of seminars is almost like a home-to-home. So I'm coming from my home to your home, or from my home to your cell phone, either one. So welcome to my home, and thanks for welcoming me into your home. As we are undergoing a new phase of dentistry, which is sit-at-home dentistry almost. It's kind of strange, but Neobiotech has a great idea of that, of while we're sitting around, let's learn together. And so today we're going to do that. And both today as well as Thursday, we've got a couple, or the main topic that we have is to introduce you to a new way that's not new, actually. It's something that Neobiotech has been doing for years, but to show you and introduce to you just how the future of dentistry, as we think about it, is actually already here, and what we can do to help with that. So let me start by sharing with you my screen, and then we will begin our seminar from here. So as we look at dentistry today and implant dentistry, I want us to begin looking at anytime loading, which is a new term that we'll kind of go over a little bit. But essentially that is, let's put the crown on the implant when we want to put the crown on the implant. The way that we've been looking at restoring implants to this point has been either through conventional means, which means that we wait for a few months for that to heal and be ready and prepared for the crown to come on. Or we do a delayed loading, which is a few weeks after the initial placement of the implant. We do an early loading, which is maybe within a few days to a week after the surgery. Or we do an immediate loading, which is at the time of surgery that we place a healing abutment. But we're going to talk about doing an anytime loading and a different method for that. And so with anytime loading, there involves a couple of different steps that we need to do. Anytime loading means that we're going to restore this implant whenever we, as the dentist, would like to or would recommend that we put the crown in place. That could be at the time of the surgery. That could be at the time when the gums are healed. That could be later on. But you'll be able to understand how to do that, to do it successfully, and to do it predictably and based upon science, so that you will have an excellent result with that. Now, if we go back in history a little bit, Dr. Brannemark is the one that began the process of us knowing when is it appropriate to place a crown on an implant. Dr. Brannemark developed this protocol, and we'll go into this a little bit so that you understand, because what we're still working on is we're still working on information and processes that Dr. Brannemark started for us that essentially said that we need to wait for 3 to 6 months after the surgery before we can begin restoring that. And so my question to you is, if that was good for us back in the 70s and 80s and 90s, why are we still waiting 3 to 6 months in order to restore an implant? And why are we still doing that to place our crown? There's a lot of things back in the 80s that we don't necessarily need to have around. The mullet is something that went out in the 80s, and we've come a long way since then. So why have we, and why are we still in dentistry, still thinking about things back in the 80s as far as recommendations of when we should restore an implant? Now, instead, the reason that Dr. Brannemark designed that and said this is why we need to wait for 3 to 6 months is because of resorbed bone or dead bone that was around our implants. There's also the implant design did affect the way that osseointegration happened. And the surgical protocol that was being used back at the early days has completely changed. The flaps that were done were very extensive flaps that exposed a lot of bone. As we expose bone, we get bone loss and other potential difficulties that will come. The drilling sequences that were used back in the earlier steps of implant dentistry involved a lot of drills. And the more drills and the more time that we're having a drill touch bone, there's a chance that we could be killing or overheating that bone. And there was not a tap drill. And we're going to talk more about a tap drill. There have been phases of when a tap drill has been used in implant dentistry and then times when it's not been. I think that's a big key to why we should be using and having good success with that. So we'll talk about that a little bit more. Some of the other things that we're going to go over in, let's get, come on. Sorry. We've got it frozen up here just a minute here. Let me close down the Q&A section just for a moment here in order to get, there we go. All right, so one of the things of why there is the delayed period is the necrotic bone. Now, back in the early days of dentistry, we talked about bone dieback of the first 2 to 3 threads. In essence, why was that bone dying back, and why would we have 2 to 3 threads of implant exposed? It was because we were killing the bone. And as we killed the bone with the placement of the implant or the drills that we were using, that was causing that bone to actually die and not be viable. There was also a remodeling process that happened that after we were drilling the bone and after we placed the implant, that we had to wait for a period of time for that remodeling process of bone to actually regrow around the implant. If that bone did not regrow around the implant, we ended up with a fibrous encapsulation that was there and present around our implant. And so why do we need to reevaluate things? Well, we've changed a lot of the way that we do surgery from the way that Dr. Brannemark originally did his. Implants have changed tremendously and amazingly with both not just the design of the implant, but also the procedure of how we place that. And then finally, the prosthetic protocols that we use right now to restore our implants have also changed dramatically. And so for these 3 reasons, I say it's time to reevaluate the way that we are considering the placement of implants and then also the restoring of implants. So what I want to show first is that there is success with this. When we began, or when Dr. Brannemark began, he started looking at implants and immediately loading those implants. We're going to cover that, but first let me talk to you a little bit about some of the studies that have happened from Neobiotech. Neobiotech has done not just 1 or 2 studies of just a few implants, but hundreds and thousands of implants that have been placed. For example, this study that was a 7-year study, it was on the posterior maxilla and placing implants into the posterior area, either in a class 1 scenario where there is no contact or communication with the sinus, a class 2 placement of an implant, which has what we would call a bicortical plate stabilization, or the cortical plate here, that the apex of the implant would engage, and then also the cortical plate here. There's a class 3 implant, which would be a crestal approach sinus lift and placement of the implant, and then a class 4, which is a lateral window implant and placement of that with the bone graft. From the earlier results of this particular process, you can see the success rates down below of doing this. And so to begin with, I want you guys to understand that this is success and that there is plenty of success with this. And so based upon the posterior area of the maxilla where we've got D3 or D4 bone, we're getting 98+% success rate in placement of implants in that area. Another study, and this was done with 2,600 implants that were placed. These implants in these next few slides that I'll show you were placed in either the maxillary anterior, the posterior, the mandibular anterior, mandibular posterior area. Overall success rates of all of these, and I'll break this down to show you, was 99% success rate. with this particular technique that, that we have with Neobiotech implants. As we break those 2,600 implants down, the immediate placement, there was 960 implants that were placed immediately upon the surgery of the implant itself and placement. Of those, 98, almost 99% success rate throughout the mouth in the mandible as well as the maxilla was recorded from this particular study. In delayed immediate placement, which means that you were placing that within a couple of days to maybe a couple of weeks of placement of the temporary or a final restoration. There were 324 of those implants that were placed with a 99% success rate. Also, with this, the immediate loading section of that, there was 510 implants that were placed that were immediately loaded with a temporary and or a final restoration that was placed with that. Early loading, meaning within a few weeks to a month or two, the implants were loaded with the permanent or the final restoration. And there was almost 900 of those implants that were placed and restored. And again, success rate, I cannot overemphasize the success rate of these for this particular study of what was happening. And so when we start to look at this system or the way of placing or the protocol of placing an implant, I want you guys to understand that this is not just a new thing that's coming out. This is something that's been going on, and this particular study began back in 2011 and went to 2014 in order to have and to illustrate these results. Maxillary posterior area, success rate of that also in the 90+ percentile. The immediate loading or early loading in the sinus area, there was also quite a large and huge success rate in that with 400+ implants that were placed. And so there is throughout, wherever you're placing these implants, where in the protocol and procedure of placing them, it's all together. It's combined together. The way that this implant is placed and the type of implant that's placed is important in order to have this particular type of success. In a study that was done with Brannemark implants or the precursors to Nobel, there was 384 implants that were placed in basically same area where this particular study was done. This is a 10-year study that was done with, again, immediate and early loading implants that were being placed. They were placed strategically throughout the mouth, either as a single implant or multiples or full arches that were being placed. From this study that is separate from the previous study that I just visited with you about. The previous study was by Neobiotech. This one is by Nobel with Brannemark implants and Nobel implants that were placed. The founder, the beginner of this process. And so in this particular study, there was early loading that was done in posterior areas of the teeth. And with that, there were things that they had as protocols for that particular study. For this particular protocol for early loading, they needed to be able to splint the implants with a temporary. There needed to be more than 3 implants, and then being able to stabilize those implants together and in unison throughout the mouth with the occlusion was part of the parameters for that study. And so that's what we've been taught, is splinting posterior implants that you're placing immediately. If you're wanting to early load or immediately load, then you're splinting and doing that. This one was placed, or this implant was placed in the 90s. And at the 90s, this implant was then followed through all the way to 2016. This results that we were getting from this, excuse me, that just went backwards. Excuse me. There we go. This particular study showed success with that. But with these implants that were placed, again, they were splinted together. There was multiples, and the occlusion of that was evaluated and made sure that that was going to take care of and to stabilize everything, and had success rates. Here's the results of the success of this particular study that was done with the Brannemark implants. Throughout the mouth and the various regions that were done, full arch and anterior implants had the highest success rate. Multiple posterior implants, both upper and lower, had a lower success rate, and single or individual implants had even a lower success rate. But the average of the 384 implants that were placed was a 91% success rate. A very close and similar studies, but just different results based upon the placement and the protocols of the implants themselves and the type of implant. And we're going to cover that more in detail. So from this, one of the things that was noted was in order for osseointegration to happen, that the loading time may not be the key factor to that. And so from the Brannemark study, what was determined was that the key factor that would cause or allow osseointegration to happen with their implants was that the implant needed to be immobilized. And so if you were to load with a temporary restoration, an immediate implant, the ability to immobilize this implant was the key that the Brannemark implants suggested for treatment of that. But again, even with the immobilization, 1 out of 10 implants was lost. And that resulted in the process of where we began looking at having all-on-4 to all-on-6 to multiple implants that were being placed, in the idea that you are going to lose some implants as you do that process. And so that's where we began the technique of saying, let's increase the number of implants that we're placing so that when we lose some, hopefully we won't lose all of them in one strategic area, that we would lose some extras in the meantime and still have the ability to restore this complete arch. What we're going to say at NeoBiotech is that you place the number of implants that you need to have, not extras, not over planning, but just plan well. And so being able that Brannemark study showed that being able to immobilize those implants was the key that they suggested for their implant procedure itself. Now, as we start to look at the results from this, there's what we call a stability change that happens. And this is something that you guys are familiar with. But essentially what this is saying is that when we do an osteotomy and place an implant, the bone that's existing around the implant will slowly die over a period of a few weeks. At the same time that we place that, there is secondary bone that begins growing around our implant at the same time. That intersection that happens at this particular crux in time is the weakest point in time when our implant is placed, that we have to be very careful, or the patient does. So between this 6 weeks to 1.5 week period of time, the patients have to be so careful with what they're doing and how they're eating or chewing that we don't want to lose an implant. That creates what's called a stability dip. That stability dip is when the implant is at its weakest point in time. And that particular time and range of time is when we don't suggest from that Brannemark study that we load an implant at that particular time. The Brannemark study showed that if you're going to load, you load early or you load late. You load after 6 weeks or you load right within the first week. And that's when the Brannemark study showed is the time that we would make and do that suggestion for that. And so what we're going to do is to talk about the difference of that and loading the implant whenever I want to, or anytime I feel like, or anytime I choose as the dentist to load that particular implant. That's what we're going to suggest is the time to do that. Now, to do that, we've got to address this stability dip, and we've got to be able to change that somehow. And so implant companies began looking at surfaces of the implant. They began looking at changing the protocol of how we're going to do our osteotomy. And so by changing some of the protocols of the actual osteotomy creation and other things, that created a change in this particular pink dip and changed it to this dip, which means that we're not having as much bone loss as quickly as we were in the initial phase of things. We also went and changed surface areas and other things of the implant itself to begin and encourage new bone growth to happen faster, which created and changed part of our dip to be a higher dip. And so implant companies in general have gone through and have changed the technique of how they place the implants and do the osteotomy, and also how the surface of the implant is created to create new bone and faster, which has changed our total dip area. In that particular change, we're better, but we're not quite where we need to. The purple line says this is where we need to be in order to avoid that dip that still is happening, even with the changes what all implant companies have been doing with the surface of their implants and with other things. There still is that dip that exists at around that 4-week period of time. What I'm suggesting is, in order for me to feel comfortable at placing an implant in anyone and restoring that at any time, I need to have something closer to that purple line. I need to have something that the bone is not going to die back, or that the new bone that's growing is going to be replaced exactly the same as the old bone that is dying. I need a stability dip that is essentially gone, or is a slight, very, very slight area that you can see right underneath the words total stability, that there is a smidgen of a dip, but that's all I want to have. I don't want to have a true dip that's there. And so in order for things to change, there's multiple things that had to change with that. The type of implant, the style of implant, the surface area of the implant, the thread design of the implant, the actual placement protocol of the implant, all of those things had to change from the early Brandemark studies in order for us to be able to have confidence and to have stability that's there. It sounds like it's a lot, but it's actually not as much as you think. And so let's look at a couple of things. So first of all here, from the physiologic placement, there are areas where we need to have the implant fit passively in the bone, and areas where the implant needs to fit actively. And by actively, I mean that it's going to compress bone. Now, when I say that, there are areas that in order to compress bone and have an active fit of where the implant is, there has to be a lot of blood supply to that particular part of the bone. To fit passively is where you will have almost no blood supply. So cortical plate, is an area where we need that implant to fit passively. Area where it can fit actively is in the medullary bone. Medullary bone has a lot of blood supply to that. And so if we're going to have any type of compression or active placement of that implant, then we want to have that in an area where there's a lot of blood supply. This is what Dr. Hull created as what he calls the Cmi fixation process. We will cover that and go more over that. So what this does, by being able to have a passive and active area where the implant is making contact with bone, it delays the remodeling process. It delays or stops the death process of bone from compression necrosis. It also allows, with the surface of the implant, to then encourage bone formation, not because we're wanting to fill in for the bone that is necrotic, not to fill in for the bone that has been lost due to our osteotomy that we're doing, but instead bone formation that is actual integration to the implant itself, not filling in the void, but encouraging and growing bone that will actually attach to the implant itself. And the placement of that implant to eliminate any micromotion, that is also accomplished by having areas where there is passive fit of the implant and areas where there is active fit of the implant. And we can eliminate the micromotion of that implant after we have placed that in the mouth, that will enable the patient to eat, to chew, to treat that as they are. We all know that they are using and abusing our implants. We may tell them not to eat on that, but they are. We may tell them not to do things, but we have to assume and know that they are doing that anyway. And so as we look at this, the process that I'm talking about both today as well as Thursday is the fixation design or the osteotomy creation. We're going to talk next week or next Thursday about the implant design, the surface design, and then also scientifically, how do we know if the implant is ready? Is there a predictable way to feel comfortable with knowing that my implant is integrated, that there is the ability to restore this implant and to do that easily so that even our assistants can do it. We don't have to be involved in that process. So first of all, as we begin this process, let's start with the assumption that I need to have the purple line at the top. I need to have that fixation process and that integration process be what that purple line is. And that's my standard of where I need to have in order for me to feel comfortable with placing an implant and then restoring or placing a temporary crown or a permanent crown on top of this implant at any time. First, let's describe a little bit of what Dr. Hall says as the CMI fixation. And so the C area, he divided the implant into 3 areas. First, the occlusal portion of the implant, he labeled as the C for the crestal fixation. The M is the middle area of fixation, and in the I is the apical fixation portion. And so there are 3 areas of the implant that we need to have different amount of active or passive pressure that's being placed on the bone as this implant comes into place. And so this is what Dr. Hall described as the CMI fixation that he developed and created an implant company from. Dr. Hall is a prosthodontist by trade. He still practices. He is one of the few CEOs of a company that actually is still a practicing dentist. And so he does both research still as well as placement, and is involved in the process of his implants and the implants of this company very intimately. He knows the process of what needs to happen from a dentist standpoint as well as from a manufacturing standpoint, and he combines both of them together. That's some of the difference between the advantage that Dr. Hall has with this particular company, is that as a dentist, he has complete control over what happens with his company. Now, in order to have primary stability, there is areas that need to have compaction as well as areas that need to fit passively. In the posterior area of the maxilla, where we've got D3 or D4 bone, as we begin our osteotomy, we would place our osteotomy and do that to the diameter that would be appropriate for the size of implant. Then we would come back in the area where the cortical plate is, and then we're going to widen that strategically and specifically in order to fit the implant. As the implant is placed in, you can see that in the medullary area of the bone, there is compaction that happens. That self-compaction that happens is not in the cortical plate area. It is in the medullary space where that compaction happens. And that is a key for what happens and why this implant is placed differently. In a straight self-compaction implant that happens, the implant both compresses the cortical plate as well as the medullary bone itself. In compressing both of those, that creates a problem. And so in order to have true CMI fixation, the C area of the implant needs to fit passively in that particular area so that we don't compress the cortical plate area of the bone. In the M area of the implant, that is area where it is safe to have compression or compaction of the medullary bone. The I area of the implant, in the example to the right of a class 2 fixation, where that is getting bicortical or biplate compression and also stabilization with the implant at the apex coming into contact and engaging in the surface of the sinus, whether there is a bone graft that's placed there or whether it is just a small bump that we would do to move the sinus membrane out of the way. But having the compaction area in the medullary space and passive area where the cortical bone is vital and important with this. As we move forward to like a class 3 implant, where we are doing a crestal approach sinus lift and then placing our implant, there still is the bicortical plate stabilization that's happening, where we are compressing in the area where the medullary bone is, and in the area where we've done our bone graft, there is essentially no fit of that. The bone is passively laying in there, and so we now have passive bone that's fitting in there. In the class 4, which is a lateral window sinus lift, that particular implant is stabilized just in the occlusal portion of the implant. The C and a little bit of the M area is all that that one is fitting with. And so which area is more important for anytime loading in a variety of these sequences, whether it is in the upper, in a sinus lift, in the second one, the eye fixation, the second diagram where we have an extraction or an immediate, where we're only getting the eye portion of the implant to engage, or an area where we have lost a lot of buccal plate typically, and we're having to do a bone graft that's there. We're getting some stabilization in the M and in the eye, and then also in an immediate extraction to the far right is where we would have some cortical plate stabilization, but not others. So which area is most important for this? We'll go over that, and that describes a little bit of if we were to apply a force to our implant, which area would be the most damaging for that force to be applied to? Would it be to the C area, to the middle area, or to the apical area of the implant? That force is then transferred from that direction to different areas of the bone. And so depending on the force that's being applied is going to determine which area of our implant and which area of our area is the most important for that. As we continue with that same thought and moving towards some studies here, as we place an implant in the Cmi fixation there, the most stress that is being concentrated is in the crestal area of our osteotomy as the implant is being placed, because that bone that is in the crestal area is our cortical plate. That bone does not bend, that bone does not move, as well as the medullary bone. Medullary bone will move and it will compress. As we put our stress in that C area of our implant, as we place that, that is the most important area that we have to pay attention to for any time loading to happen. As we go back to the early 90s and 80s when we were having the 2 to 3 thread dieback that was happening, that again was happening because that crestal area of the implant was being compressed. As we placed our implant, we were compressing that cortical plate, and as we compress that cortical plate, we get dieback. I'll show you an x-ray that's going to show that in an example. Insertion torque is also important to have, because as we are inserting an implant into place, we want to make sure that we are not placing excessive amount of force on an implant. But what happens if we can't get very much torque on an implant? What happens if we're just in the 10 to 20 Newton centimeter of torque? That is where we suggest that the implant is covered in a 2-stage sequence, where that implant is buried and then allowed to heal. If we're able to get 20 to 30 Newton centimeters, at that point we can place a healing abutment, but we're going to want to allow that to heal a little bit longer. And so if our bone is not have the ability to place the implant and then torque that implant to 30 Newtons, that is one of the requirements for immediate loading, or for any time loading to have, is that we need to be able to achieve 30 to 40 Newtons of torque. Now, the second thing with this is that we should never exceed 40 Newton centimeters. From Dr. Hu's studies that he's done, if we exceed 40 Newton centimeters in our torque of our implant at any point that we're placing that implant, we are compressing the cortical plate, and as we compress that cortical plate, we will have dieback. We will have necrosis of that bone in that area that we are compressing. And so Dr. Hu's studies show that the torque that we're placing on an implant is important. In this particular photograph right there with the yellow arrows, this is the area where there was some excessive force that was being applied to this particular implant to torque it to place. By having some excessive force that's being applied, that causes that bone to die back. And you can see around that implant on that x-ray that there is bone that's being lost around that particular implant. And part of that is due to the fact that that implant was not placed passively and actively in the appropriate places. So that brings us to a dilemma. If our C fixation is the most important part of that, and overcompression of that causes bone loss. How do we overcome that, and how do we create a situation where we can place an implant and have the correct amount of pressure, passive and active, in the appropriate areas of the implant? And so with this one, the first illustration here, we're going to do a full drill and then a self-tapping drill. So we're drilling our osteotomy site to the appropriate diameter and dimension, and then we're going to self-tap that also. First, here's our osteotomy that's been created, and then the implant is placed, just like typically we do right now in the majority of recommendations. In doing that, we are, as you can see, placing some excessive pressure in the area of the cortical plate by the threads that are going in. The threads themselves in those small areas are placing more pressure on that cortical plate than they should. In the second illustration, we're going to use a countersink drill. And with the countersink drill, we're going to be able to widen the cortical area of the osteotomy just a little bit more. Well, in using that countersink drill, we're heading the right direction, but our threads are still placing in certain areas too much pressure on the cortical plate. And as we put too much pressure on the cortical plate, that area of the implant will die. And so just in the areas where the threads are making that excess or extra contact with that, we will have dieback. Now, if we do an osteotomy and then come and do a tap drill, where we're providing or creating the threads in the bone where the implant will fit. At this point, we're removing bone in an area where, so that we won't create excessive pressure with our outer edges of our threads. And the implant will fit in passively in that area, but intimately in that area. And so that's what we're talking about with the difference of the placement of an implant, is being able to have an area where we are placing our implant appropriately from our osteotomy, and then we are placing and using tap drills with that. In this illustration, this is how the majority of us are placing implants to this point. We're compressing and compacting all of the bone that's there. And so as we compact or as we compress our cortical plate, we're having and placing too much pressure and too much, and we'll have pressure necrosis that will begin from the most occlusal portion of the implant. To use the Cmi fixation with this is where we want to have passive area or fit with a tapping drill, and then we want to have active compressive area in the medullary space. In order to do that, we have to have a tap drill that aligns almost perfectly with our implant. By doing this, the purpose of the tap drill is to remove bone, but it removes that bone in an exact fit for the implant to come into. In other words, we're pre-threading the bone so that the implant will fit in ideally without having to compress or cause excessive force to happen on that implant or on that bone. And so this is what it would look like as we place this. We have our typical and standard osteotomy, and then once we've completed the osteotomy, in D1 bone, we're going to use a long tap drill that we're going to pre-tap the entire osteotomy. Now, even at this, if we pre-tap the entire osteotomy, if you look at the torque that's being placed, particularly there at the occlusal portion, this is where we're going to have pressure necrosis and where we will have dieback or death of bone for a couple of threads, just like the x-ray that I showed you a few slides back. That's what happens even when we try a little bit of a tap drill, but it still is not taking care of that most coronal portion of our osteotomy. That is the secret. That is the most sensitive area of dieback that we have to be careful with. And so if we're going to place this one properly with a D1 or D2 bone, we are going to do our osteotomy to the appropriate size. We're going to do a long tap drill to place threads throughout the entirety of the implant itself. And then we're coming back with a separate or an additional tap for that coronal portion or the C portion of the implant. As we then place the implant in place, it fits passively where it needs to fit passively, where there is little to no blood supply with that. And so at this point, our implant is placed with 40 Newton centimeters or less of torque. And by doing that, we're creating a scenario and a situation where our implant fits passively where there is minimal or no or little blood supply. And in areas where we have D3 and D4 bone, we can have compaction with that. So this can be placed in the anterior as just as illustrated, or previously as we illustrated, it can be placed in posterior areas where we have a lot of medullary bone. Now, at this point, let's pull up the question and answers, and let's see what do we have with that. So let me engage with this, and I'm going to stop sharing my slides and then come up and see if there's any chat questions or any other questions to have that you would like to ask. And so if there's anything, any questions or any concerns that you would like to have, please type them in the question and answer portion of that, and let's visit with this. So this is just our first segment of the process of placing that, which is our osteotomy. In using our osteotomy, we're not using excessive drills. We're using a minimal number of drills like the majority of other implant companies are suggesting too. But the difference with this is that we're making sure that we are having the size of the osteotomy be very intimately fit and fitting the implant itself. And by having that very intimate and precise and accurate fit of our implant to our osteotomy, we're not going to have excessive compression that's going to happen on our bone, which will and does and continues to result in bone loss, dieback as we call it, or that stability dip that we're creating. So the stability of the dip that's coming is actually coming from me. I'm the one that's causing the stability dip to happen. And so the question that comes in is what would be the difference of using a tap drill versus the next size drill on the cortical portion of the osteotomy? So you're starting to think the right thing. You're starting to think in the right direction, which is let me increase the size of my osteotomy a little bit. Let me use a next size drill to do that. In the one illustration that I did that showed the three side by side, the tips of the threads are still having too much compression in the cortical area of the bone. And so though it's better and we're thinking the right direction, I like what you're thinking, but we're still getting, with the extent of our threads, we're still getting too much pressure that's being placed on that small cortical area of the bone. And that area is the area that from Dr. Ho's studies and Neobiotech's that show that that is the most vital area and the most sensitive area that needs to happen with, or needs to be taken care of with the bone itself. What RPM are you using for tapping? And so the tapping itself, great question, thank you. The drills themselves are used at a slow RPM. They're used at 50 to less is what I use my tapping drill for. And so I'm going in with water. I use water on essentially everything. And I'm going in at a slower RPM. And so 35 to 50 RPM is the RPM for the tapping drill to come in. So you're recommending using a tap drill in both immediate and delayed implant placement. And so great question too, thank you. So the tap drill is essentially there whenever we have less blood supply. And so in an anterior area where I'm placing an implant, I'm going to tap drill both on an immediate as well as on a standard that has the bone already placed and existing. And so I'm going to use, in the anterior area, I'm going to use a tap drill both on an immediate as well as on a standard implant or standard implant placement that I would do where the where we have already lost a tooth. We've done our GBR techniques in order to make sure that we have good and accurate and enough bone that's there. I'm going to tap drill those always in the anterior area. Posterior areas on an extraction tooth that you would do where it would be an immediate placement, I'm only going to be tapping that portion where I'm coming in contact with the the cortical plate. So for example, if I'm placing a lower molar and my size of my extraction area is this big and my implant is this size, I am not going to tap that, because the cortical plate of that particular area of the implant is not going to come in contact with my area of the bone and that implant. I'm going to be grafting or bone grafting that area to fill in the void where the tooth came out or was extracted from that. In a premolar or in an anterior immediate, I am going to be tapping those and using the tap drill on a premolar and on an anterior to make sure that if there is contact with the threads of my implant, that I am going to have that area tapped, so that I'm not going to be increasing the amount of force of the threads that are going to make contact with that implant in the area where I have less or little blood supply that's coming. And then another question: do you place implant submerge, or when do you place and submerge an implant? And so right now, when I submerge an implant, it's if I am not able to get the proper torque. And when I say that, if I'm getting less than 20 newtons or 15 newton centimeters of torque, anything less than that, I'm going to completely submerge that implant. Anything more than that, or higher than 15, I'm going to place a healing abutment on that. If I'm getting between 20 and 30 newtons centimeter of torque of my torque wrenches I'm placing that implant, I'm not going to immediately load that one. I'm going to use what I'll introduce next time is an any check. And an any check is the ability to detect exactly how much contact that implant is making with the bone. We'll talk a lot about that on Thursday and give you guys a lot of information about that, because that is one of the keys of what we'll need to do in order to know if we're ready to place a temporary on this, or if we're ready to go to a crown as soon as we're ready for that. And so I am submerging an implant mainly if my torque is not appropriate. If on an immediate extraction, if I am getting a fair amount of torque with that, but still need to do a bone graft, I would do a bone graft there, place a membrane, and then I typically am going to place a healing abutment and do a gathering stitch of the gum tissue to gather that around the neck of that healing abutment, so that I have a primary closure around my healing abutment itself. Great questions. Any other questions that we have before I turn it back over to a Young? Well, wonderful. Well, I am grateful for your attendance, and as a fellow dentist that's a wet finger dentist just like you guys, I can hardly wait to get back to work again. I'm driving my wife and family crazy, probably like you guys and gals are too, and worried about our practices and worried about everything else. But let me just assure you that that this will pass. You know, it will be a time that things will come and go, and we will be back to a new normal, but we will be back to a normal. Also, I want to have you guys look at and would suggest that on Mondays and Thursdays, we're going to be doing this while we're all sitting at home, you know, for the next period of time. And so tune back in to the Neobiotech and look and see what others are going to present, because throughout the next couple of months, we're planning on every Monday and Thursday doing some presentations that hopefully you'll find interesting and be able to take back, or to say, this is something that I would like to learn more about and to have more information about with that. So let's see, there's a couple more questions that came in, and then Young, I'll turn it back over to you.
All right.
You're welcome. All right, Young, it's back to you. You're in charge.
Sure. Yeah. So it looks like we answered all your questions. Dr. Platt, is there anything else you would like to mention?
I don't think so. I think we're good. So
Okay.
Thank you.
Okay, great. Okay, and thank you very much, Dr. Platt, for your presentation. And now, thank you very much. And now I will make some announcements. Now I will share my screen here. Okay, so So for upcoming webinars, if you're interested in taking our webinars, you can find more upcoming webinars in our website. Just go to at www.NeobiotechUSA.com. And once you scroll down this page, you'll see more webinars. And for the next one for Dr. Platt is the future of implant dentistry here, part 2 on Thursday, April 23. So just mark this date, save the date on your calendar, and it's still the same time at 11 to 12 p.m. Pacific Coast time. So next one, I want to go over some the CE. So in order to receive your CE, you'd have to stay until the end. And thank you very much for those stayed. And your one of our sales rep will email you the link to complete the course evaluation form. It should be looks like somewhere like this, and there should be more questions in the bottom. And please be advised that the course evaluation form will be closed the next day, which is tomorrow at 1 p.m. Pacific Coast time. So we will provide your CE 1 CE credit upon completion of the course evaluation form. Okay, so I hope everyone is clear on this one. So at the end of this webinar, the sales rep will email you the link. So please complete the course evaluation form, and this form should take no longer than 5 minutes to complete. So, and thank you very much for participating in today's webinar, and we hope to see you again next time. And please feel free to contact me if you have any further questions. You can also contact me. My email is right here, ayoung.chui@neobiotechUSA.com. All right. Thank you very much. Okay. Thank you very much again for coming, and thank you, Dr. Platt, for the presentation again.
Good. Look forward to seeing you on Thursday.
All right, great. Thank you. I hope you guys have a wonderful day. Bye-bye.
Thank you.
No worries.